But some patients, like when they need to take warfarin. So what does the warfarin do?
It brings out the blood to don't coagulate as fast.
Okay. Now I told you like two pathways. One, there is the liver is sending the factors, and then what do the factors do? Thicken the blood. So that is called what? What's the verb? Coagulate. That's the coagulation. Is that clear, guys? All right. On the other pathway, what did the platelets do? What's the verb?
Aggregate?
Aggregate. And what does aggregate mean? Making a paste. And then so what does the paste do? It's a glue. They come and then glue the cut. Does that make sense? One is gluing the cut, the other one is thickening the blood. Together, what are they doing? They're controlling the bleeding. Does that make sense? And then so like you're not afraid, you know? So like you go on with your life. You just wipe you that a little of the right blood and then you go on with your life. Do you agree? Mm-hmm. All right, so now you have a patient, like my son, all right? So like he has a metallic aortic valve. So he has to take Coumadin forever. So what is Coumadin gonna do? Where is it working? This is the factor, this is the platelets.
In the liver.
No, they're not. It's only they're going to be working on the factors. Factors. So what warfarin does, it doesn't let the factors to thicken the blood. Am I making sense?
Does it inhibit the release of the factors?
Yeah, it deactivates the factors. Okay. All right. So what did the factors do? They were thickening the blood. Now warfarin comes and says to the factors, "I'm not going to let you thicken the blood." Am I making sense? Mm-hmm. So in other words, if the blood is not thick, it takes longer to be thickened. Am I making sense? Mm-hmm. All right. So for that reason, like if you're taking warfarin binds to proteins. So there is very little free warfarin in the blood. So for that reason, do you know from the beginning, like what dosage you're going to give to that patient? No. There is no standard dosage. So like you give 5 milligram, you check the INR. You give another 5 milligram, you check the INR. If the INR is 3.5, that's the goal for my son. So then the doctor will say that 15 milligram is the dose that you're going to be taking. Am I making sense? Mm-hmm. So why you don't predict? Because the whole molecule binds to protein. So there is very little free Coumadin in the blood. Does that make sense? So how do you know? Because 10 milligram for you is different than 10 milligram for you. Does that make sense? Because everything makes a difference, like body type, body shape, the weight, everything makes a difference. So for that, it's like my son is going to be taking 10, 10, 10, 10, 10, Saturday, Sunday, 15, 15. But like if there is like a small girl, petite, 10 milligram is going to be too much for that woman. Does that make sense? But both of them have the same problem. Let's say they have artificial valve. Am I making sense, guys? Mm-hmm. So in other words, for that reason, so the medications that they bind to protein and then we don't know how much free they are, we have to test it with the blood work to see what is the dosage that is suitable for this person. Is that clear? But for Tylenol, we don't measure anything. Everybody takes Tylenol. Young, old, I'm not going to say that, not old, because like old, the kidney function if it's not, or the liver. Okay, so in other words, all of us here in this room, we can take Tylenol, 2 tablets, and then we're kind of ensure that our headache is going to go away. Is that clear, guys? Because Tylenol is all free. It doesn't bind to any proteins. So for that reason, the dosage can predict the effect. Yes?
So when the medication does not bind to protein, it's distributed faster?
Yes. Yeah, because it's free.
And then when it's binded to protein, it distributes slower? So
yeah, because we don't know how much free there is. So the only way you know how free it is, you have to do blood tests.
Okay.
Yeah, for that reason, you're going to be taking the heparin, like 10 milligram or 5 milligram. Definitely, my son is big, so 5 milligram is not going to do anything to him, right? So so we know that much. So, but still, we start slow. Okay. Yeah, you start slow, then you check the blood work, right? So the INR is 1.2, nothing. We want 3.
What does INR mean?
INR is, I'm gonna explain this. Let me explain it. So the key is, so when we cut ourselves right now, so nobody's on Coumadin, all right, so and then we have a timer. So how long does it take for this blood to thicken? to coagulate. The other verb is coagulate, to thicken. How long? 10 to 12 seconds. 10 to 12 seconds. It's very fast. In other words, right away the factors thicken the blood, and then so we see that our blood that is flowing, what happens? It dries because it thickens. So 10 to 12 seconds. Does that make sense? So that's the control. We are all controlled because we're not taking any Coumadin. So it is because body types are different, there never can be one number. It is between 10 to 12 seconds. All right, so somebody is 10, 10.2, 10.3, 1, 11, somebody is 11.5. Does that make sense? So it's between 10 to 12. But that's the control. If so my son has to take a Coumadin because of his valve. There is higher potential every time that the blood is passing through the aortic valve. So because it's metallic, it's cutting the cells. You can't control it. It's a metal there. So what happens every time there is cut inside, there is going to be coagulation inside. Am I making sense? So for that reason, his goal, the INR should be 3.5, meaning that, so if you're taking 10 seconds to coagulate, he has to take 35 seconds to coagulate. Does that make sense? So for that reason, we have to find the dosage that is going to ensure 35 seconds. So the INR is the ratio between the control and your patient. Is that clear, guys? So if somebody has atrial fibrillation, my mother has atrial fibrillation, for example, she's on Coumadin, but her INR, if it's 1.5, is enough. Does that make sense? Because with the atrial fibrillation, the atrium is doing this, and then so sometimes there is a potential for pooling of the blood. Pooled blood can coagulate. Does that make sense? So it's more prophylactic than therapeutic. Am I making sense? But when you have a valve that is already metallic, it's not. It's therapeutic. You're not preventing. In other words, it's happening. Am I making sense?
So INR is just a
ratio.
A ratio between like therapeutic versus
the control.
And then my second question is what's an example of a protein binding like medication?
Warfarin.
Warfarin. Okay.
Warfarin. That's what I said. So warfarin is protein binding. So we don't know how much it binds, how much it's free. Does that make sense? So for that reason, you won't know. It is different from one person to another person. So for that reason, you have to do the blood work to identify the right dosage for that specific patient. Does that make sense? Yeah. For the Tylenol, do we do blood work? Everybody takes Tylenol because it doesn't bind to protein. It's free. It's going to go to its destination and it's going to do its work. Does that make sense?
So is that the same thing as like or would you have to run the same blood test for like levothyroxine and all those?
Thyroxine is a hormone.
Uh-huh.
That's hormone level. That's you're seeing the function of the thyroid gland.
The blood test would be different. This
is different. Yeah. You're just assessing. Yeah. So you're just assessing how much the thyroid gland producing the hormone. Okay. Yeah.
You said with protein binding, so if a drug has a high protein binding capacity, then they have also a high potential for toxicity, like the warfarin.
The thing is, if it is high binding, so you don't know how much free it is, you don't know the dosage.
Okay.
So that's the thing. You have to you have to do lab work.
So you have to like monitor them.
Then you have to do more monitoring. That's why.
Okay.
Yeah. Okay. Okay. Okay, I explained this already. And then, so the other thing is that, so like the key is, there are a lot of medications, so like we said it, we're taking it and it's going into the stomach and it's getting digested and then it's going to be absorbed. And there are medications that like they're passing through the liver. So when they pass through the liver, we lose the effect of that medication. Okay, so what is the function of the liver? To metabolize. What is metabolize? To make it less effective. Does that make sense? So in other words, we have to see the medication, is it going through the liver as a first phase? Then that medication is going to be less potent. So that medication has to be given more of a dosage. Am I making sense? Okay. And then the excretion is mainly the kidneys. I already kind of said it. Why? Because it's selective membrane, and it selects like who has to pass through it and go out with the urine, and then who has to stay in. Okay, and then so what is this? All right, so now there is, every time we're giving medication, you have to understand that there has to be therapeutic range. This is subtherapeutic. Okay, so you can take this medication here, and then like it's not doing anything. You think that you're taking medication, you need a fact, it's not doing anything. All right, so this is subtherapeutic. This is therapeutic. So in other words, the medication dosage or the concentration has to be within this level to give effect. Am I making sense? And then the toxic is we have to stop the medication. All right. Okay, guys, let me explain this. Now, since I gave the warfarin example. All right, so let's say we gave my son 5 milligram of warfarin, right? And then we check the INR. We check the INR. INR is 1. What does that mean? He is equal to control. Am I making sense? So in other words, so the control is 12 seconds. He is 12 seconds. The INR is 1. Am I making sense? As if he is control. He took 5 milligram Coumadin, but he's acting as if he didn't take anything. Am I making sense? Mm-hmm. Are you with me? So the INR is 1. It means that no difference was made. Okay, if we're going to give my son 5 milligram, 5 milligram, 5 milligram, 5 milligram, the INR is 1, 1, 1, 1. He's taking medicine. But where is the medication? Subtherapeutic. Am I making sense?
Yeah.
So in other words, it's subtherapeutic. He says, oh, I'm taking medicine. Yeah, I know you're taking medicine. But that 5 milligram is doing nothing, as if you didn't take anything. How do I know? We did the INR. What was the INR? 1. What does that mean? As if it is control. Am I making sense, guys? Mm-hmm. All right, so it's subtherapeutic. If the patient is functioning on a subtherapeutic level, so yeah, you're giving medication, but like you're not making any change. Am I making sense? So subtherapeutic level. So it's you're taking medicine, but like it's not changing. It's not affecting. It's not thinning the blood. He's gonna have blood clots. All right. Okay. So then, what does that mean? We have to increase the dose. Are you with me? Mm-hmm. So then, like you go into 7.5, and then you do INR again. Then you gradually go into 10, and then you do the INR again, till you reach your goal, and then you see like what dosage gave me this goal. Then that dosage becomes his dosage. Is this clear? So for that reason, the Coumadin from one person to other person to other person, the dosage is different. Am I making sense? Because it very much depends on the physiology of that person's body, even the sex of the person, the shape of the person, right? Okay, are you with me? Yeah.
Would you say that that's his INR then, or how do you say that?
Which one? No, that's his therapeutic dose.
Therapeutic dose.
Yeah, the INR is lab test. The only it's confirming. The INR is only lab test to confirm. Is that clear, guys? So that's the therapeutic dosage for my son is 10, 10, 10, 10, 5 days, 15, 15, 2 days. So that's how like he's taking it right now. Okay, so that's his therapeutic dose. Anything less than that, it's going to be subtherapeutic. Is that clear? He takes the medication, but like he's not going to be seeing any effect. Are you with me, guys? Mm-hmm. All right, so that's why. All right, so anytime like you're giving anticonvulsive medications, you have to do the levels. You have to do the levels because the anticonvulsive medications, they can easily go into toxic levels. Am I making sense? So for that reason, like you're going to be doing this. Okay, so peak and trough. When I was working at Parkland Memorial Hospital, so still gentamicin was given. Gentamicin is a very potent antibiotic, right? So we did the peak and trough. What is peak and trough? Just like half an hour before to trough peak. Okay, trough. So half an hour before you're going to give the medication, let's say you're going to be giving gentamicin IV at 10. So at 9:30 you have to draw blood. Is that clear? So what is 9:30? It means that the medication is its lowest. Am I making sense? So it has to be in the therapeutic level, right? Okay, so it's the lowest. Then you give the gentamicin. Right after you give gentamicin, you draw another blood. All right. So what do you want the blood to show? Within the therapeutic range. Does that make sense? If it goes to toxic range, then we have to stop gentamicin. Does that make sense? Because if it is going to the toxic range, what is the side effect? Not side effect, it's adverse effect. Ototoxicity and deafness. Do you want like your patient to be deaf? No. So then you stop the gentamicin. Does that make sense? It's very important. So in Armenia, they weren't doing pick and trough because this is a special test. All right, so like what was happening that the mothers from the villages, like if there is the child is a spiking fever, they're carrying and then to the nearest hospital. This is like in the regions, obviously. And so like without pick and trough, they were giving like this gentamicin. And the kids are like, deaf. And then like they're saying, okay, life or death. No, life and death together. We don't want them to die, and then we don't want them to become deaf. Like it's 2023, right? So like, why aren't you doing pick and trough? It's a special blood test. Yeah, I know it's a special blood test, but is it worth losing hearing? Now, like there is this, my friend, like she started all this hearing thing, like she implemented. Now there is a protocol to do this pick and trough. Does that make sense? So in other words, once you are on toxic level, you don't give because you don't want to lose the hearing. Is that clear? Yeah.
How do you know that they reach toxic level?
Oh, blood test.
But the blood test, like, what are you reading?
Okay, the lab knows that what is the therapeutic level. There is a range.
Okay.
There is a range. This is therapeutic range. Anything above that, it's toxic. Anything below it, it's subtherapeutic.
And it's based on the person's age and...
Yeah, and then also the age, and then also the body type, and yeah. So I've done a lot. I don't know how prevalent it is now, but like in 1986, 87, like I was working at Parkland Memorial Hospital, and these patients have a central line. You take the blood from the central line, so you don't even have to prick it. So that is totally nurse's responsibility. We didn't even call the lab. All right, so you take the blood, you send it to the lab half an hour before, then you administer the medication. Right after the medication is administered, you take another blood, you send it. And then you have to follow up. What was the peak? What was the trough? Right? So this is totally nurse's responsibility. Okay?
When you say the drug is administered, is that after like an IV is empty?
Yes,
Okay.
yes. After the IV is empty, so then like after 10 minutes, like you take it, and then so like then you have to compare it. All right. So in other words, the medication has to be within this therapeutic range. All right. So you don't want subtherapeutic because it's not doing anything. You don't want toxic because it's going to make the person deaf. Does that make sense?
And at the trough, you're at the subtherapeutic range?
The trough is like, it's you're still therapeutic range. I mean, therapeutic range. You're not going to go off the therapeutic
You're
range.
just at the lower end of it?
Yeah, lower end of it. Very good. Yeah, you have the lower end of it, and then you're going to go to the, you're not going to exceed the higher end of it. Remember, if it is like, if it's outside the range of the therapeutic, then the medication is not doing anything.
Okay.
Is that clear? Okay. So but I have done a lot, pick and trough, so, and then it's central line, you don't call the phlebotomist, and then you do it yourself. Okay. So what is side effect? What is adverse effect? Side effect, okay, so for example, if you're taking Benadryl, okay, so what does it write on don't operate machinery because like you're going to be drowsy, right? So for reason Benadryl is given as a sleeping pill also. You take it, it's like if you have allergies, like it kind of diminishes the symptoms of allergy at the same time, like it gives you sleepiness. So like you take it at night and then you sleep, right? Okay, but like you don't operate machinery because like you're drowsy, you can go do something wrong, right? So that's the side effect. So usually like when medications, like Benadryl is first generation. So for that reason, when they brought the Claritin, or Zyrtec or Allegra, they're second generation. Does that make sense? So what does that mean? They take the molecule and they see like, why is this medication making drowsy? How can we change that drowsiness part so that it won't happen to the next molecule? Am I making sense? So it is second generation. So as the generations are up, so what are you anticipating to see? Less of a side effect. Does that make sense? So Benadryl is first generation, Claritin is second generation, Zyrtec is second generation. So for that reason, when they're advertising, what are they saying? It doesn't cause drowsiness, right? Why? Because they manipulated the molecule in a way that they kind of, that pathway that is causing that drowsiness, they controlled it. Am I making sense? So the higher the generation, the better the drug. Am I making sense? All right. So in other words, I mean, you know, I still take Benadryl. I mean, it's not a big deal. You take it like at night, you know, so it's over the counter. So it comes very handy, like when I'm traveling, you know, so you take it because you want to sleep. Does that make sense? And then also Tylenol PM, there is Benadryl in it. It's kind of mixed together. All right. So, I mean, if you don't want to, obviously, the more the generation, the expensive the medication, obviously, right? Okay. All right. So what is adverse effect? Adverse effect, I wasn't anticipating this to happen. It happened to me. That's the adverse effect. Adverse, I'm not anticipating. Side effect, I am anticipating. Am I making sense, guys? Benadryl, you anticipate you're going to be drowsy. It's already claiming because how the molecule is working on the body. Does that make sense? So, but adverse, I wasn't anticipating like what happened now. All right. So adverse effect, and then, you know, suddenly like the whole, my chest is like tight and then all red. Okay. So like, oh, I'm having allergic reaction. So what happened? Like I might die. So adverse effect, it can be very serious, in other words. Is that clear? So, and then toxic effect is the high concentration. So what was, I gave you an example, ototoxicity is a toxic effect. Like I don't want to go deaf. So that's toxic effect. I'm still alive, but I'm deaf. Does that make sense? So that's the toxic effect. Is that clear, guys? Yeah. Idiosyncratic reaction, it's like you're taking medication to reduce the pain. This medication is giving you more pain. All right, so that idiosyncratic reaction. Allergic reaction, it can be life-threatening. Why? Because the body kind of translates this as your enemy, and then it's attacking. So like, how do you react? You have chest tightness. I can't breathe, okay? So like peanut allergies, you have seen it, right? So like, okay, so what happens? Like they have to have the EpiPen right away, all right? So it's peanut, like, okay, so why I should have allergic reaction? But like the body's fighting as the peanut to be like an enemy, all right? So, okay, so medication interactions when one medication modifies, okay, so usually, you know, like people with chronic diseases, and then also like with me, like when I was doing the home visits, so all my patients are chronic, they're elderly with chronic diseases, so they can be on Dilantin, they can be on other medications, digoxin. So there is drug-drug interaction. So for that reason, like I always had to do drug levels periodically, because you never know, like the physiology of the patient changes. If they're like sick, okay, so does that change the absorption process of a medication? Like if they're having the flu? Yes. So it's very difficult like to control. And if their kidney function is not good, so kidney cannot excrete that medication, that medication stays in the body. So it will give unnecessary adverse effects. Am I making sense? Okay, so always like I had to measure drugs levels because I didn't want any drug to be higher than their therapeutic dose so that it won't interact together. Is that clear? Okay, so routes of administration. We talked already sublingual. Sublingual, I gave you an example of what? Nitro, because like we really need in 5 minutes vasodilation, because like I don't want this pain, because eventually I'm going to go into myocardial infarction if that vessel is not opened, right? So you want that spastic. I smoked. What happened to my vessel? Spastic. What do I need now? Nitroglycerin to open up. Is that clear? And I want it now. Is that clear? So nitro, which is given under the tongue, will do that. Is that clear, guys? Buccal administration, you're putting it like here. Buccal. What is the buccal? Mainly you're going to be seeing pain medications, fentanyl buccal. So for example, like if you're going to be giving medication at 8 o'clock, pain medication. Next dose is 12. Next dose is at 4. Next dose is at 8. Does that make sense? Now, like you gave at 8, the next dose is at 12. Suddenly at 10, your patient is screaming, I'm in pain. And then you come and you say, you're not due yet for another 2 hours. But what is she going to do? For 2 hours, she's going to cry. So what is this called? This is called breakthrough pain. Is that clear? Mm-hmm. So if there is breakthrough pain, so what do you give? Usually fentanyl buccal we give, they put it in the buccal and then it's sucked and then it helps with the pain relief. Is that clear? So buccal is usually given for breakthrough pain. Okay, enteral, it's enteral feeding. If you have a G-tube and G-tube, you either crush the medication or you get the liquid form of the medication and you give through the G-tube or NG-tube. Is that clear? Okay, parenteral routes are intradermal, subcutaneous, intramuscular, and intravenous. All right, so intradermal is under the skin. Did you take the PPD test for before? The PPD, they give under the skin, all right? So, and then you see if there is a bump, all right, or it shouldn't be a bump, right? So, okay, so all of us have taken that intradermal. So that's intradermal, all right? So even though PPD is not medication, it's just you're giving, and then it's a chemical, obviously, purified protein derivatives, and then so we see if the body reacted to it. All right, so in subcutaneous is the fat. So we have the epidermis, dermis, and then we have the subcutaneous tissue. Subcutaneous tissue is very good. Why? Because it will harbor the medications and let them release little by little. Am I making sense? I gave you the Lantus example. Remember, that's a basal insulin. All right, Coumadin is this, not Coumadin, heparin. Heparin is also given sub-Q, all right? All right, so intramuscular is you're giving into the muscle, all right? So the muscle, intramuscular, and then intravenous is directly into the IV, all right? So in other words, intramuscular, you're not gonna be using too much anymore. We're not using too much anymore, all right? So the vaccines that we took, it was intramuscular, all right? So it's the deltoid muscle.
Were you saying that the enteral was the G-tube?
Yeah.
How is that under oral routes?
Because it's going into the stomach.
It goes through your mouth.
Wow. You're using the GI pathway. Because the NG, if you put if you cannot eat, I'm gonna put you NG.
Okay, I was thinking the wrong tube. I was thinking of the one that goes
down
here.
Yeah, that's the G tube. Because NG tube, you cannot have it forever.
Okay, so it's the NG tube. It's not the one that's.
Yeah, I mean it's NG is nasogastric.
Okay, yeah.
The G is gastric.
Okay.
So in other words, you're using the GI tract.
Okay.
So think about that way, So GI tract starts from the mouth, and esophagus, stomach, intestines, to the rectum, to the anus. So that's the GI tract.
Okay.
All right, yeah. So you take a tablet, you can an elixir, you can take anything from the mouth. If the mouth you cannot swallow because you have a stroke, so where am I going to give your medication? I'm going to put an NG that directly goes into the stomach. Does that make sense? Because here it's paralyzed, you cannot swallow. Okay. All right. So and then the for example, intramuscular. So in other words, if somebody has you went and did a lot of exercise, then you go for your flu shot. Okay, so how is that flu shot going to be absorbed after your exercise? Faster, because you did a lot of exercise, there is a lot of blood flow there, right? So now, in other words, exercise matters as far as absorption when the IM is given. Is that clear? Intravenous is faster, obviously. Other routes, epidural is during pregnancy, during delivery, right? Intrathecal, intraspinal, intraosseous, that's bone. Intraperitoneal, it's to the abdomen. Rectal, vaginal, intrapleural, and intraarterial. So these are all routes that you're going to be using. Okay, intracardiac or intraarticular, this is by physicians. Topical administration is what? Like Bengay, if you're having arthritis, like the Bengay cream, you're putting it. Mucous membranes. Inhalation route is somebody who has asthma. proventil you're going to be taking, right? And then intraocular, it's like you're putting eye drops. Okay. All right. So these are all the routes that we're going to be using. All right. So always, like when you're putting the skin, so there are also nitroglycerin patch, you know, like the one that you have nitroglycerin that you put under the tongue. There is the patch. There is the patch also. You put the patch, and then so like it will be absorbed little by little over 24 hours. You know, so in the old days, like, you know, now the patch, you open it, like the medication is in there, and then you like a Band-Aid, you put it on. When I was a staff nurse, like in 1984, so we had like the nitroglycerin, it was like in a tube, as if it is toothpaste. And then so like we had to put like 1 inch, like this is small, I put 1 inch, and then I have to put it, and then we put the tape. So that's how it absorbed. All right, so this has happened. One nursing student, she thought like, always you remember, you think that ointments are kind of innocent. So she took she thought, and then like that's wrong that we used to leave the nitroglycerin at the bedside. She thought it is a cream. And then she put like all the patients back, and her hand without gloves, both of them died.
Because of blood
This
pressure
is
dropped?
blood pressure dropped. Yeah, so it was so bad of a practice. We used to leave those things at the bedside. This is 80s.
So if you give nitroglycerin via patch, like how you have to monitor blood pressure like every hour or
Yeah.
something?
But like already kind of we know. So if the dosages are different, and accordingly it is ordered.
Okay.
Yeah,
it's
there are the
less
patches
potent than
says.
sublingual.
Say it again.
It's less potent than sublingual.
Less potent than sublingual. Yeah, it is. The thing is that consistently it is absorbed. 24 hours it is absorbed. That's why you won't. All right. So and then so there are different dosages. Obviously, we don't want them to go on hypo.
Right.
And then the other thing is that when you remove the old one, you have to wipe, and then put the new one. Because if you don't, like then there is patches all over, so there is still residue from the others. Does that make sense? So these are like little things you think like, what's the big deal? Like, who doesn't know? People do not know, and then people die. Does that make sense, guys? Yeah. So it's very important to understand. You know, like if you understand like how this is working, and then plus like when you, even though nowadays you know like you open the patch, you really don't touch it. Still put gloves on, because like if you get a little bit of nitro, you're gonna go into hypotension also, because it will dilate your vessels too. Is that clear? Yeah. Okay. Okay, so now like we're coming to calculations, all right, so we're coming to calculations, so let me put this up so we can use the calculations a little bit. All right, so one thing that you're going to be remembering, 1 ounce is 30 milliliters, all right? So nowadays we're not using cc. Like when I was a student, we use cc. I mean, like nobody uses cc in America anymore. What is cc? It's a cubic centimeter, all right? So what do we use? Milliliter, all right? So we're using milliliter. Is that clear, guys? So all your IVs are in milliliter, okay? And then, but like because it's in America, we're still using the ounce. So 8 ounce, 6 ounce, right? So 1 ounce is 30 milliliter. So what is 30 milliliter? That little medication cup is 30 milliliter. Are you visualizing? Yes. All right, so that little cup is 30 milliliter. So in other words, it's 1 ounce. Is that clear? So 1 ounce is 30 milliliter, okay? So, and then the 8 ounce is like the cup, the coffee, that the styrofoam, it's like 8 ounces. Is that clear? That the coffee that we buy with the styrofoam cup, that's 8 ounces. So in other words, if every ounce is 30 milliliter, 8 ounces is how much?
240.
Okay, so that's how every time like you're gonna be calculating, you have to convert into milliliter. Is that clear, guys? Okay. So metric system, 0 always before the decimal, but never after. Most logically organized, meter, liter, gram. So these are the things that you're going to be knowing. Okay. So these are the things that you're going to know. All right. So meter, liter, and gram. All right. So this one we're not going to be using it. Okay. So It's so routine, it's here. Okay, we don't use this. All right, so now what we're gonna have, like the only thing that you have to remember is 1 ounce equals to 30 milliliter. All right, so if the patient have like 8 ounces, so how many milliliter is it? All right, so 1 ounce is 30 milliliter, 8 ounces how many? So like what are you gonna do? 8 times 30 over 1. All right, so what is it? This is 240 milliliter. Is that clear? So this is how you're going to be doing it. So, and if the patient had like 1,000 milliliter, which is 1 liter, so, okay, so IV fluid. So what are we doing? 1,000 milliliter if IV fluid, and this is water. All right, so now how much is here intake? It is 1,240 milliliters. Does that make sense? So in other words, this is an intake. So your intake is given by ounces. You're going to be changing into milliliter. Your IVs are already in milliliter. All right. So if the patient has gotten 1 liter of IV, which is the whole bag, that big bag is 1 liter. So you have to convert it into milliliter, which is 1,000 milliliter. Okay. So then that's how like you're going to be giving the answer. Is that clear, guys? All right, so this is like one of the questions in the test, all right? So, all right, and then I think one of the questions in the practice test too, right? Okay. So, okay, so I'm gonna keep it very simple, all right? So, all right, so now here, what do we have? The main thing you need to know is how to convert ounces to milliliters. We already said it. There are 30 milliliters in 1 ounce, I said this. And then when calculating milliliter from ounces, add up to the ounces a patient has ingested and multiply by 30. We did it kind of, right? Okay. So a patient drinks the following, so 6 ounces of orange juice, okay, 20 ounces of water, all right, and then 10 ounces of coffee, and then 10 ounces of apple juice, all right, okay, so now how many ounces is this? Okay, so let's put this is it. All right, so 6 ounce, 20 ounce, 10 ounce, 10 ounce, all right, 6, and then 46 ounces. Do you see? So 46 ounces of liquid, right? 46 ounces of liquid. All right, so now, if 1 ounce equals to 30 milliliters, and then how many ounces do I have? 46 ounces is how many milliliter? Do you see it? Right? Okay, 1 ounce is 30 milliliters. This is a given. This is a given. This is a theory. This is a given. What I need, like I have 46 ounces that my patient drank, and I'm gonna convert to see like how many milliliter is it. All right, so 1 ounce is 30 milliliter, 46 ounces, how many milliliters? So do you see here? This is ounce. My answer, I need like the unknown is milliliter. So what am I doing? 46 times 30 divided by 1. Okay, multiply, divide. All right, so 46 times 30 divided by 1. Is that clear? So this is how you're going to be getting how many milliliters. So it will be 1,380 milliliters. All right, if the patient also receiving IV fluids, you will add that to the total. Remember, IV fluids are already in milliliter. All right, so you don't need to convert. Unless if it says that, okay, the IV fluid was 1 liter, which is 1 liter is that big bag. So then you're going to convert into 1,000 milliliter. Is that clear? And then you'll add it. Okay, guys. So this is like one of the questions in the test, and then I think it was one of the question in the practice exam also, right? So okay, so we got one exam question down. Okay. Calculate and document the total amount of the fluid the patient received during your 12-hour shift. 6 ounces of water. 6 ounces of water. All right. In the AM with medication. 9 ounces of coffee. All right. And then 5 ounces of apple juice. Okay, for breakfast. 250 milliliters of IV bag infused, 250 milliliter Okay, 250 milliliters bag infused at 9 o'clock and then at 1800, which is 6 p.m. to administer IV antibiotic. All right. 250 IV bag infused at 9
Times 2, right?
and at 6 to administer IV antibiotic. Okay, so this is at 9 a.m. and then there is 250 milliliter at 6 p.m. or 1800. Okay, all right, 8 ounces of water. Okay, then there is 8 ounces of water here. All right, lunch, 12 ounces of milk, 12 ounce. You know, like I don't like the ounce because it looks like 0, right? Let me put it like this. All right, so 12 ounces of milk, 6 ounces of water, 8 ounces of peppermint tea. Okay, all right. And okay, so now add up to the total ounces, multiply by 30, divide by 54 ounces times 30. Okay, now, all right, so now what is the total? Okay, let's do it. Okay, 6 plus 9 plus 5 plus 8 plus 12 plus 6 plus 8, what is it?
54. It's 54.
How much?
54.
54, okay. So 54 ounces, okay. So we have 54 ounces of liquid. All right, and then how much IV do we have? 500. So we have 500 milliliters of IV. All right, so now, what are we gonna do? The answer has to be in milliliters. So what am I gonna do? I'm gonna convert the 54 into milliliters, okay? 1 ounce is equal to 30 milliliters. All right, so how many ounces do I have? 54. 54 ounces is how many milliliters? Okay, so 54 times 30 over 1. So what is this? 54, okay, what is it? 54 times 30?
1620.
1620, okay, 1620. So 1620 is the liquid. All right, so what am I gonna add to this? The IV. How much is the IV? 500. 500 is the IV. So what do we have? 2,120 milliliters of intake. Is that clear? Yeah. Okay. So this is this question is going to come to the test. IV fluids already in milliliters, so don't convert. Okay. Total is okay. We already did it. Okay. Very good. All right. So metric system. Okay, all right, so this is obviously, so like when you have gram, it's weight, liter is volume, the liquid, meter is linear, like, you know, so what it is like you have the measuring tape, right? All right, so the key is, all right, so here, the weight, okay, so this is the kilogram. So if we have 1 kilogram, so how many milligram is it? 3, you're gonna go down 3, 1, 2, 3. So in other words, 1, 2, 3. So 1 kilogram is how many gram? 1,000 gram. Is that clear? Gram is a smaller. Okay, so 1 kilogram is 1,000 grams. So if we have 1 gram, so you have 1 gram here, so you're gonna go into milligram, all right? So you're gonna go three places. So 1, 2, 3. So it's going to be 1,000 milligram. Do you see? 1 kilogram is 1,000 gram, and then 1 gram is 1,000 milligram. So like when we're going towards the right, so what happens? Like it becomes the number becomes bigger because the measure is like the milligram is like more minute. The kilogram is bigger. Am I making sense? All right. So then 1 milligram is 1,000 microgram. Okay, so 1 microgram. Okay, so 1 milligram. 1 milligram. This 1 milligram is how much microgram? 1, 2, 3. 1, 2, 3. 1,000 microgram. All the thyroid medications you ask about the thyroid hormone, they're given in microgram. Do you see? So all the levothyroxine, the hormone, if somebody has hypothyroidism, so they're taken in microgram. Is that clear? Okay. All right, so, all right, microgram volume. Okay, so 1 liter is 1000 milliliter, 1 length meter and kilometer. When converting large to small, move the decimal point to the right. When converting from a small to the large, we're gonna be converting, we're gonna come to the left. One thing that I want you to know, okay, so if we're converting, let's say, so we have, let's say 50 gram, 50 gram or milligram, we're gonna go to gram. It doesn't matter. So we have 50 milligram, for example, right? If you're gonna go into grams, so you're gonna go 3 spaces, 1, 2, 3, all right? And then so 0.05, okay, so what do you write here? 0.05 gram. Do you see? So you don't need to put the 0 after the point. But you have to put the 0 before the point. You don't write 0.05 gram. This is very misleading because I might not see that point. Is that clear, guys? So if there is a point, there has to be 0 before it. But like if there is a point after the point, you don't need to put it. Like for example, if this is like 5.0 gram, all right, so you write 5 gram. You don't have to put 0.0. Am I making sense? All right, so but if you're gonna be writing 0.5 gram, you have to put the 0. You don't put 0.5 gram. Okay, I might not see this point, or somebody else doesn't see the point. Is that clear? So this has to be enforced, okay, in the test also. All right, so the metric system. All right, so we already said it. 1000 milliliter is 1 liter, 1000 milligram is 1 gram. So you see it. So what happened there? 1000 milliliter, where did we go? From a small to big, right? We have 1000 milliliter, 1000 milliliter, right? So you're going liter. What is the liter? It's bigger, right? So what are we doing? 1, 2, 3. So what is this? Do I write 1.0 liter?
No.
No, what do I write?
1.
1 liter. Do you see? All right, so do you see there? Okay, so if there we have like 1000 milligram, so we're gonna go to gram. Milligram is smaller, gram is bigger. Where do we go? Left. Okay, so that 1, 2, 3. So what is this? 1 point is here. 1.000 gram. So what do I write? Only 1 gram. I don't need to write this. Do you see? Because after point, zeros do not count. Is that clear, guys? Okay, so like any 0 after the point, don't write it. Even if it is like this 1.50, so don't write this. Just point 1.5. Is that clear? Okay. So all right. So then 1 milligram, I have it. So it's gonna go to microgram. So what is microgram? Microgram is smaller than milligram. So also, so this is 1 milligram. I'm gonna go to microgram. Microgram is smaller. So where do I go? 1. This is 1, 2, 3. 1, 2, 3. So what's gonna happen? It becomes like 1 milligram becomes 1000 microgram. Okay, to convert from one to another, we just have to move the decimal 3 places to the right or 3 places to the left to convert from large to small. I think we said this already. Examples. So if we're gonna have 0.05 gram, we're gonna go into milligram. Milligram is smaller. Where do I go? 1, 2, 3. So what is this? So it's gonna be
50.
Okay, so where did we put where did we bring the point? Here, we point the, so what happens then, at this all goes, all right, so it is 50 milligram. All right, so then the decimal moved 3 places to the right. We have like 1.25 milligram, so we're gonna go into microgram. What is microgram? Smaller. So where do I go? Like 1, 2, and 3. So I'm gonna add another 0, and then I bring the point here, right? So the point is here, but does it matter? No. All right, so it's 1250 microgram. Is this clear? Yeah.
On theory, you write gram as GM, but on usage calc, it's just G. Do you have
No, GM.
GM?
GM. Okay, did you hear what she said? Write GM for gram. Don't write. I know I see some people write it capital G. Capital G. No, let's put it lowercase GM. Is that okay? Because that's what you're going to be seeing in the hospital. GM. GM, lowercase, not a big G. Is that clear, guys? Okay. All right. So now we have here 1 milligram. We're going to go to gram. What is gram? Gram is bigger. So let's do it. 1, 2, 3. Okay, it's going to be 0.6231. Are we good? Are we? Do you all feel comfortable with this? Yeah. Okay. Was this helpful? Me doing it? Yeah. Okay.
Will we need to know the other ones or just those three? The kilogram, gram?
That's 3. Yeah. Yeah.
microgram?
That's it.
Okay,
That's it. That's it. That's the metric. Don't. Yeah. I know there is another grain. I am not asking grain. You know, like grain on. I learned it in the school when with my BSN. I mean, I think I only used in Lebanon one time. Never, like 40 years I'm here, I never used it. So I don't want you to learn the grain because it's additional information. No grain.
It is on the practice exam.
That's okay. Do the practice exam. John Christensen wants it. I took it off from the test.
Okay.
Yeah, one last thing because I don't want you to get confused. Because I never used in 40 years in America. So, you know, like I only used in Lebanon one time, 1 year. Okay, so I don't want to overwhelm you with things that you're not going to be seeing it. Does that make sense, guys? But for the practice, do it. It's a you're at home, do it. Okay.
I meant the like deci, like deci and like the hecta. And
No hectare,
Okay.
there is
Just-
none. I don't know this, I'm not going to test you. If I don't know, I don't test. Isn't that nice? Isn't that good? Like she's recording me now. But it's nothing wrong, you know. So like we don't use hectare anymore, you know. So all right, yes.
A lot of questions on the homework have a lot of like tablespoon, teaspoon. Do you want us to?
I think, let me see. I'm going to check if there is a tablespoon or teaspoon. Like even the teaspoon or tablespoon, we're going to convert into milliliter. Yeah,
like-
milliliter.
Okay, so.
Yeah, if I'm going to ask the tablespoon or teaspoon, I'm going to say like 1 teaspoon is how much milliliter, so that you can have like you have to convert it. Is that clear? Because what is teaspoon or tablespoon? It's a volume. Like it's a, what do you put in the teaspoon? Like you're putting liquid medication to give to the child, right? So then it has with milliliter, right? Okay, yeah.
We should know conversion between kilograms and pounds at 2.2.
That one, yes, because we're using it. Yeah, 2.2. 2.2. Yeah, now like everywhere is going back into kilogram. Yeah, you know, so, all right, so, yeah, so, yeah, that one you have to know. 1 kilogram is 2.2 pounds, all right? Because medications are with kilograms. I think for that reason now, like even doctors' offices, they're weighing the patients with kilograms because now the one less step to convert. Because if you're using in the doctor's office medication and you're going to use kilogram, you might as well think kilogram from the beginning. Are you seeing that trend also? The weight is like now we're not doing with pounds anymore.
We put the pounds in the computer and it automatically converts it to kilograms.
Kilograms.
It goes on that person's
Yeah.
information. As
That, yeah, they have to facilitate it because like really, that's, yeah, very good question. But we're gonna ask that, 1 kilogram, 2.2 pounds. Anything else? Yeah.
On the test for, I know this is like really nitpicky, but do you want commas or no commas?
Commas for what? Like 1,000? I don't, I know, don't put it. I don't think we need, we don't need to put it like less characters. Yeah.
We're not gonna be counted wrong.
No, I won't count.
Because on dosage calc, they want it.
They do it?
Yeah.
Okay, put it there.
I mean, if we're not gonna get counted wrong.
Yeah, I'm not gonna count it wrong, right? Yeah, what is it, Tatiana, what did you say?
No, because some question count in comma like wrong answer. And odds are not, so we don't know like what comma.
I'll
what
check
is it
again.
as.
Let me see like what did Christensen put as a wrong number, because if he put the comma or not. I'll check on that, huh? Okay. Yeah. All right. So what else? All right. So that's that. Okay. So should we do this? All right. So 2.3. Oh, I'm gonna change this. So no G, GM, and then lowercase. I'll fix this. All right. I'll fix this. All right. So 3.2 gram. So we're gonna go into milligrams. So we're gonna go 3 decimals. 1, 2, 3. So what is this? Okay. So 3200 milligram. Okay. All right. So then we have 1,200 milligram. 1,200 milligram. So we're going into grams. So we're gonna go into a bigger unit. 1, 2, 3. So what is this? 1.2 gram. Right? Did you get that? All right. Okay. Now we have 0.03 kilogram. All right. So we're gonna go into gram. Gram is smaller, so we're gonna go to the right. Okay. So 1, 2, 3. So we're gonna add a 0. So it's gonna be 30 gram. Right? 30 gram. All right. We have 3,500 milliliter. We're gonna go into liter. 3,500 milliliter. We're gonna go liter. 1, 2, 3. So what is this? 3.5 liter. All right. And then we have 520 milligram. So we're gonna go to gram. Gram is bigger. So we're gonna go to the left. So 520 milligram. We're gonna go to gram. So 1, 2, 3. It's 0.52. It should be 0.52. 0.52 gram, right? Okay, so you have here 750 cc. You're not going to be seeing cc in the units. What does that mean? Cc is milliliter. It's the same thing. You see? Okay, so it is 750 milliliter. You're going to go to liter. Liter is bigger. Okay, so then you go 1, 2, 3. So what are you having? 0.75 liter. Is that clear, guys?
And for liter, you use capital letter or small letter? Because it's
it doesn't matter. Like you can write liter or let's put it capital L.
Okay.
Yeah, I think it's easier. Okay, guys. I think I'm not asking this. I think the grain. I took the questions out. I know there is one practice. Just practice it for the sake of practice. But like I'm not gonna ask the grains. Okay. Yeah. Yeah. Okay. All right, these are all calculations you're gonna learn in the lab. Is that clear? Okay, let me only do one example, then we're gonna close this. At least let me go and then explain another topic, then the pharmacology. Okay, all right, guys. Let me see here. Okay, so okay, now there is a doctor's order, and then there is the medication that you have on hand. All right, so now this came from the pharmacy. Okay, so there is the pharmacy. Okay, and then there is the physician. All right, so now the physician puts the order. All right, now the pharmacy sends the medication. Okay, so the nurse has to follow order considering the medication on hand. Okay, what does this mean? So now the physician puts the order. Then you go and then look, okay, so what do I have on hand? So this is what I'm going to be using to give to the patient, right? So then what are you going to do? You have to convert the physician order to the one that is on your hand. Am I making sense? Yeah, because this is what you're going to give the patient. So this is what it matters, in other words. Okay, so then like you're going to be converting to the medication that you have on hand and then give it to the patient. All right, let's see here. I think, all right, so the dosage strength which is found on the medication label contains two parts: the strength of the medication with the unit of the measurement, or the specific volume of the liquid that contains in the strength. Okay, so these are like what you have in hand. Here, Miss Mesna injection, 1 gram per, so this is like 1 gram per 10 milliliter. Okay, so there, if in this, I think this is 10 milliliter. The whole thing is 10 milliliter. Okay, so then in the whole thing there is 1 gram of this medication. Here the Acupril, so what is it? There is 5 milligram per tablet. All right, so when the physician says that, okay, so the order of the physician is Acupril 10 milligram per day, and what do you have in hand? Okay, so you have like 5 milligram per tab. So what are you going to give? 2 tablets. Does that make sense? So in other words, this kind of goes and then adapts to the one that you have in hand. Is that clear? Okay, so in other words, 1 tab has 5 milligram. Physician order says 10 milligram. So how many tablets I'm going to be giving? So 10 times 1 over 5, so which is 2 tabs. Am I making sense? All right, so now here, the basic formula, all right, so the desired times the quantity of the vehicle amount to be given on hand. Okay, and anyway, so the order is Cipro 0.5 gram PO every 12 hours. All right, now, so the order is given by physician, right? So what is the order? It's 0.5 gram every 12 hours. All right, so every 12 hours. Now, what is the available Cipro is, so the pharmacy brings you what? Okay, so the pharmacy is giving you what? Okay, so the available is Cipro 250 milligram tablet. All right, so 250 milligram tablet. Okay, so this is what you have. This is what you have. The doctor is saying 0.5 gram every 12 hours. What I have is Cipro 250 milligram. I have milligram, I have gram here. The order is saying gram. So where do I convert? The order has to abide to this one. Am I making sense? Because this is what I have in my hand. Is that clear? Okay, so in other words, you convert the order to the one that you have in hand. All right, so first things first, I have Cipro 250 milligram. I have the order in gram. The first step is what? To change the gram into milligram. All right, so I have 0.5 gram. Gram is big, milligram is small. I'm gonna go 3 spots, like 1, 2, 3. So if this is 0.5, so what happens? 1, 2, 3, so it's gonna be 0, 0. So what is this? This is already 500 milligram, right? So this is 500 milligram. So what's the order? The order is 500 milligram every 12 hours. So now it is like 8 a.m. So what am I going to give? So 500 milligram. So what do I have in hand? So 250 milligram per 1 tablet. All right, so the order is 500 milligram. And then how many tablets I'm going to give? So 500 times 1 divided by 250. So I'm going to give 2 tablets. So 2 tablets I'm going to be giving at 8 a.m. and then 2 tablets I'm going to give at 8 p.m. So together, like how many tablets did I give over 24 hours? 4. Does that make sense? So this is how we're going to be doing. I think we did good as far as the medication. Yeah. So how do you feel?
Good.
Do you feel good? Yeah. So this is how it's going to be the test also. So it's not going to be something that you didn't see, in other words. Okay. All right. All right. So let's take a stretch break. We only have like anyway 15 minutes left. Can somebody help me with the erasing? So that I can check like what's left. What do we have? Thank you. All right. So let me see. Where are we now? And show. Okay, let's go to the modules. Thank you. Okay, let me discuss this a little bit. We only have 15 minutes, then you'll know about it. So I think like I gave more focus on the pharmacology because like I think it's more anxiety generating. You needed to know it better, right? Okay. All right, guys. Okay, this is only 14 slides. Okay, so. Okay, what do you think about John Sharp? Whoever he is, I don't know him. So the moral of the story, like if you have like a goal, you want to go somewhere, that's your outcome, you have to establish the process. Am I making sense? So any outcome that you have, it's a result of a process. Do you agree? So in other words, so if you got an A to the class because like you studied very hard, right? Okay, so the process leads to an outcome. A process leads to an outcome. So in other words, if somebody smoked and somebody didn't watch the diet and now like there is a heart disease, okay, so because the process led to that outcome. Am I making sense? So in other words, there is an outcome and then it's a result of a process. So if you want an outcome, you're very much kind of you want a distinct outcome, you have to put like very well established a process, a structure to follow to get that outcome. Does that make sense? So that's what this person is saying. Okay, so like if you want in the future, like you have these big goals and then you have this big outcome that is you're visualizing to attain, then like you have to work on establishing very well structured process to lead you to that outcome. Am I making sense? So in other words, we cannot take chances. Is that clear? There is no chance. I mean, suddenly you don't wake up in the morning and then everything is nice. No. So like, because like so like if you see it, like if somebody's going, a bride on the wedding day. So how much planning does that take? A lot of planning, right? Why? Because they have this vision that they want that day to look in a certain way, right? So that's the outcome they're desiring. For that reason, they're putting a big process. They're hiring like a consultant, whatever, So, I mean, my wedding dress, my mother sewed it, so I don't know. So, no, bad. So- it's not that bad, so like it depends like from which angle you look. So in other words, the moral of the story, every time there is an outcome, it's a result of a process. And if you are very distinct about that outcome, you have to be very structured regarding the process. Do you agree? We can't leave things to chances. Okay, so that's what it's trying to say. All right, so institution does not come to an unprepared mind. Okay, so kind of more or less. Nursing image, how others see us as a profession. How did we get there? Here. How do we get out of here? So what do you think? I mean, like obviously you're all very passionate. You applied for this program, like it's very difficult to get in. And then so like you're in. So like what drove you? Obviously, like you have a vision. I mean, everybody's driven to a profession that is very, it kind of reflects them, so like it has to, like if I'm a nurse, like that's me, so like, how did you feel? Like, why did you come into nursing? I'm listening.
Yeah.
I'm gonna have a hard time with this enable editing. I'm enabling.
Are you pressing the other button? Press the other button.
Which one? This one?
Yeah. Try enable editing.
Hold on. Yeah, thank you. Okay. All right. So tell me, why did you come to nursing? Yeah.
I was my stepdad's caregiver when he had cancer and we were in and out of the hospital. And the nurses were the ones that we were with the most, and they were really helpful throughout the stay. So I loved their dynamic when we would go into the ER, even with my grandpa. The ins and outs, the hustle bustle, I really loved.
But
how
like
much care
before,
they give.
but obviously you had another career, right? So like you had a bachelor's in something else, right?
I was in biology. I did medical assistant.
So like you had just like it was a science, but like you didn't know which
No,
route you were gonna
no.
go, and then so this was a reason for you.
Because you're more hands-on with nursing, I think. Like MDs, they see so many patients, they go diagnose and leave, but nurses are the ones that stay with patients and.
Okay, so that
But
was
more
the
hands-on
drive.
care.
You wanted like to be involved with patient care.
Yeah.
Right. Okay. And then so what others like? Why did you go? What is the image of nursing when you talk in the society right now? Like how are nurses seen? Is it a respectful profession? So what have you heard?
I think after COVID, nursing kind of it became a lot more
Valuable.
respectable, valuable. People realized how essential nurses were to the whole healthcare dynamic, and how much nurses really are first responders, and it kind of brought up the nursing image.
Okay, very good. So like in other words, it was as much as it was like an unappealing experience to have the COVID and the shutdown and the pandemic, but like it kind of boosted the image of nursing. Okay, very good. All right, so okay, so like you said, like in the media now we have like a better vision or better value because of the pandemic. And then before then, what was it? How was it?
I think people just thought of nurses as like a doctor's assistant or something like.
Yeah, I mean, always there is this, people went to biology, they applied for medical school, they didn't get into, and now like they're going into nursing school. So like, in other words, like the people think that, all right, so like you didn't achieve like the medical school, now like you're going into nursing. So like it's kind of like a backup plan. That's how the society looked, right? So what did you feel? How do you feel? I mean, you're free, like, tell me.
I mean,
There is no
I
right
don't
or
think it
wrong.
was ever viewed like that.
Huh?
I don't think in my life, I don't think it's ever viewed as a backup plan.
Okay, that's a good thing. Yeah.
It was primarily a female profession, and especially when what was that movie with Ben Stiller when he's like a man nurse?
Meet the Fockers.
Meet the Fockers, when he's like a nurse and he gets made fun of by his in-laws for being a male nurse.
Yeah.
So that was kind of the idea, like the social aspect of it. But I mean, I feel like they've always been known to like make really good money and have flexible scheduling, and the license transfers to a lot of places, like different states and things like that.
Yeah, I mean, that's a blessing, because like, pharmacy is not like that. For example, you have to take the whole test, a board exam again in another state. But like starting in the beginning of 80s, so that they came to a consensus that in any state you can transfer your license. You don't have to take the test again. So that's a given. That's a very good thing. So it gives you flexibility to relocate if you are given a better job in another place. So there is a lot of flexibility. Yeah, very good. And then there is a lot of autonomy also, because if you're a nurse practitioner, you're working under your own license. You're not dependent to another provider to provide their license so that you can function autonomously. Very good.
I feel like that's something that has like come to light lately though, because I feel like when we were kids and stuff, like my parents didn't want me to see a nurse practitioner or a PA, they wanted me to see a doctor, but nowadays like it's kind of the norm to see a PA or an NP.
Yeah.
And,
Very good.
not a doctor.
Because the doctors are going into more specialty, and then primary care is being done by nurse practitioners and the PAs. So, and then also the technology and then education levels, the standards have gone higher. So you remember, like, in the mid-1960s, nurse practitioners started it. How did it start? Because rural places, they didn't have providers. So the nurses were trained in the hospitals to become nurse practitioners, right? So that they can be providers. But then eventually Kaiser, at the beginning, like they trained nurse practitioners within the Kaiser system to become nurse practitioners to work within Kaiser system, because they needed providers. But like when I got my NP in 1993, it became the rule that you have at least to have master's degree. You can't be trained in the hospital. So you have to go into university process and then get a master's degree to be called nurse practitioner. So within your master's preparation, you're preparing to become an NP. So in other words, you said it, like as we're growing older, so nurse practitioners are becoming more keen, more well prepared to be primary providers. Very good. Good point. Anybody else?
Well, I was just gonna say that the industry changed so much. When my grandmother was working in healthcare in the 70s, the way she described it to me was, the doctor would order the medication 10 times the dosage, smoke in the hallways, and walk down and never see the patient again. And that's just not how it is.
Right.
And the nurses are now responsible for so many more medications because new medications are being created, and all of this is just being lumped onto the expectations. And so I believe that everybody's skill set sort of went up a little bit, where all of the nurses were expected years ago to be nursing assistants, and then the doctors were doing, medications. And now, the medications are responsible at the nursing level and really everywhere. And the providers are now going up to being specialists. And so everyone's really getting more responsibilities as the medical field's becoming more complicated and more specialized, and that's changing the image so much so.
Very, I think we started a very good discussion, but I have to conclude the class because the time is up. So my focus was the pharmacology. So I think the pharmacology we did it. The rest of the slides that are there, you're going to be learning in the lab. All right. So next week, so it's going to be week 3. I know I'm behind with the topics, but I will catch up. All right. So we'll do it, and then also we'll catch up with the topics. All right. Okay.